You're welcome. Good evening, everyone. Welcome to this MVSS New Horizons webinar series. Tonight's topic is the future of aortic repair 2024 and beyond. We thank Terumo Aortic for their generous support for this particular session tonight. We have 4 great talks lined up, and I encourage everybody to please use the chat function to put questions in the chat, and we will have time for discussion after each one of the talks. So Dr. Cho will go ahead and introduce our first speaker and our first talk tonight.
Good evening, everyone. Tonight's first talk will be started by Dr. Ravi Ambani, who is an associate professor at Cleveland Clinic Lerner College of Medicine. His clinical interests include aortic and carotid disease. He also has interest in surgical education and serves as an editor for V-Score. And he's going to give us a presentation today on one-year outcome of EVAR. Dr. Ambani, thank you.
Good evening, everyone, and thank you for the opportunity to speak today. As Dr. Cho mentioned, my name is Ravi Ambani, and I'm currently one of the staff surgeons at the Cleveland Clinic in Ohio. Tonight, I'll be discussing what we've learned from our one-year device data and how it affects our outlook on the durability of EVAR. So I have nothing to disclose in relation to this talk. Abdominal aortic aneurysms and their treatment has evolved over the years. The current SVS guidelines recommend treatment of infrarenal abdominal aortic aneurysms at a size of 5.5 centimeters in all patients, with consideration of treatment in female patients at a size of greater than 5 centimeters. Treatment of these patients can be accomplished via traditional techniques of open surgical repair, or newer techniques with endovascular repair with endografts or fenestrated repairs. The difference in techniques led to the all-important question of which treatment plan is better. Several landmark trials, including the EVAR-1 and OVER trial, were conducted and showed improved early mortality with EVAR when compared to an open repair. This could be explained in part due to the minimally invasive nature of an EVAR, but long-term follow-up for these trials showed that open surgical repair compared to EVAR was better for mortality and decreased late aortic rupture. So, with a significant number of options on the market, a few of which are displayed here, we as clinicians need to individualize our treatment based on various criteria, including aortic anatomy, vessel size, and resource availability. But how do we choose between doing an EVAR on someone or performing an open repair? And if we choose an endovascular approach, which device should be implanted into which patient? To answer this question, I think we need to focus on the goals of our treatment strategy. When treating aneurysm patients with endografts, the main objective, as we all know, is exclusion of the aneurysm. However, with endovascular exclusion, patients who have persistent growth from pressurization of their aortic sac are still at risk of treatment failure. And this treatment failure can lead to increased risk of late rupture and mortality. In an effort to evaluate what factors affect sac enlargement, Dr. Shanzer and his colleagues looked at the compliance with individual device guidelines using an imaging database, M2S. They shockingly found that overall compliance with established IFUs was low, while aneurysm sac enlargement was quite high in this population. The main reasons for treatment outside of IFUs were short aortic neck angulation, and small external iliac arteries. The high number of patients with sac enlargement is a strong prognostic indicator for the long-term risk of aneurysm rupture. Although several studies have shown that growth is mostly related to the presence of endoleaks, a stable or shrinking aneurysm diameter after EVAR is largely considered a successful treatment modality. More recent studies have shown that patients who have sac regression after 1 year, when compared to those with growth or even stable aneurysm sizes, have significantly better long-term outcomes. This includes less freedom from intervention, less rupture, and lower overall mortality. In 2010, Habula et al. Were one of the first groups to look at the impact of significant sac retraction, or what we now call regression, on EVAR success. They found that 25% of patients had a significant sac retraction at 26 months. Survival in this group was significantly longer, with no incidence of a rupture or surgical or endovascular conversion during that time frame. In 2018, utilizing data from the VQI population, O'Donnell and colleagues looked at the effect of sac regression on long-term survival. Over 30,000 patients had 1-year follow-up imaging and were included in this analysis. At 1 year, 40% of sacs regressed, while the remaining 60% remained stable or even expanded. They found that over time, sac expansion or stability was associated with the development of new endoleaks, mainly type 1 or 3 endoleaks, and overall failure of the sac to regress was associated with increased long-term mortality. More recently, in 2020, Antonio et al. Performed a meta-analysis of 8 studies encompassing over 17,000 patients. The pooled incidence of sac regression at 1 year was 48%, and these patients had a significantly lower hazard of death, secondary interventions, and late complications. Their relative risk of rupture was also significantly lower than in those without shrinkage. So if sac regression and aortic remodeling is the main objective, how do we as vascular surgeons accomplish this goal? A group of Dutch researchers attempted to answer this question with their systemic review. They utilized 2 databases and found that neck thrombus was a negative predictor of aortic shrinkage, whereas on the other hand, patients with aortic thrombus, low lumen volume, and aortic calcifications were advantageous in promoting the sac remodeling. When I review the data from the available products on the market, it's clear that there's still a lot of work to be done. As our patients age, we have to think about the long-term sequelae of implementing all these endografts. If we don't know or understand what features of aortic anatomy are predictive of sac regression and aortic remodeling, we can't predict which patients will fail their endovascular repair in the long run. Research comparing all the currently available devices in a head-to-head fashion is necessary to determine which device designs are advantageous in decreasing long-term failure. So in conclusion, EVAR is clearly beneficial in the short term with less morbidity and mortality compared to an open surgical repair at a 1-year time. By promoting sac regression, there's a long-term survival benefit and a decreased risk of aortic rupture. We need to perform further research into device-specific design and function to understand how to maximize this aortic remodeling and decrease the risk of late endograft failure. Thank you all for your time, and I'm happy to take questions when we discuss them.
Great, thank you so much. I again encourage everybody to put your questions in the Q&A. One question I have is, you spoke a little bit about aortic related mortality in regards to sac stability or sac growth, which makes sense. How do you kind of square the fact that all-cause mortality tends to be higher in patients who have sacs that aren't remodeling and aren't shrinking? What do you think you've seen, or are there any clues as to why those might be linked?
Yeah, so that's a great question. I think, in my opinion, I think people that don't remodel well are for a couple of reasons. Either you have, an early endoleak that you're not managing, even type 2s, which lead to late, 1 or 3 failures, or they have some sort of biologic milieu that's not letting them, kind of this inflammatory state that's driven up, that's not letting them kind of remodel. I think we see this in dissection patients, in IMH patients, that, the same patient, everything stable, one remodels at 3 months, the other just expands and looks worse. I think we're trying to figure this out. I mean, in the dissection world, we have high-risk criteria that we're looking at now, but I still think we don't fully understand the idea in aneurysmal growth.
Great.
Robbie,
Sorry.
Robbie, thank you for a nice talk.
Of course.
What sort of guidelines do you exercise now with the current data that you have just presented? Is there any simple guidelines that you can recommend to younger generation of surgeons, or any principles that you would recommend? Thank you.
Yeah, I think with the long-term EVAR1 data, I still am leaning towards open repair in younger patients, younger healthy patients. It's just my personal practice guidelines. I think when the patients are a little older and they are suitable for a endograft, I will still talk to them about the benefits in the short term, but I'll also describe the long-term issues. Some patients don't want for me, CT surveillance, or to take that risk of that 10 to 20% reintervention rate over their lifetime. And in those patients, if they're young, healthy, and cardiovascularly fit, then I'll offer them an open repair. In the others, I think I generally stick very within IFU. So if they have a longer neck, I'll use devices that are beneficial for that. I think if they have shorter neck anatomies, then we will discuss whether that's a complicated just endograft with some added fixation, or if it's a fenestrated repair. I think that's something to discuss with the patient.
We have a couple of questions from the audience, and first one is, what modality or software do you use to measure aortic flow volume?
So that was just kind of one study looked at. I still use Recon for most of my aortas. I think using Recon at least gives me good centerline images and helps me measure for my devices. But that aortic flow volume, I don't exactly recall what software they used, but I could look into it.
Teresa, do you have a comment about this?
Well, I think there was another question just asking about how people were, who's doing preemptive sort of management of lumbar embolization to induce sac thrombosis and minimize type 2 endoleaks, or other adjunctive procedures.
Yeah, that's a great question. I've been thinking about that as well after when I was preparing this talk. What is my personal threshold? Maybe we should, I don't have an answer, but maybe we should be more aggressive with these type 2s. I think if you're not, maybe at a year, if you're not regressing and you have a type 2, even though maybe you didn't grow, if you haven't shrunk, maybe that is an indication to go after these type 2s to see if you can induce some sac regression. I think there was a paper that was published after VAM, I think 2 years ago, that showed that sac regression less than 4.5 from baseline around 4.5 centimeters, those patients did better than people that only had 5 millimeters of regression. So maybe we should be more aggressive.
Great. Well, thanks so much. Our next speaker is Dr. Christina Ryan, who is going to speak to us about challenging aortic anatomy. Dr. Ryan is an associate professor and the medical director of vascular surgery service line, as well as the director of quality and patient safety and the acting division chief at The Ohio State University.
Great, thanks, Tressa. Hello, nice evening. My name is Christina Ryan, as she just mentioned. I'd like to thank Midwestern Vascular Surgical Society as well as the New Horizons Committee for inviting me to give a short talk this evening on challenging aortic anatomy. I have no disclosures. So I'll start out by just saying that IFU is important. We've all been doing endografts now for about 20 years, and there's been lots of studies out on the market in multiple countries that show that once you go outside the IFU, we have increased graft-related complications and we have decreased patient overall survival. So I'll start out by just saying that, and most of us like to color inside the lines when we can. So lots of guidelines, our society guidelines, guidelines from the actual vendors themselves for the endografts, all suggest that we should stay within the IFU for the best outcomes. But those of us on the call this evening are in real life clinical practice, and we know that some of us have to color outside the lines, and there's as high as 40% of cases are performed actually outside the IFU. And I'd say that some of these are done with many acceptable outcomes. Certainly there are situations where we want to do endovascular approach first. So in the setting of a ruptured aortic aneurysm, where we're really trying to stay endovascular, even though most of us would like to stay and color inside the lines, we frequently will have to stay mostly within the lines, and certainly the color needs to go outside of the lines in order to achieve our goal for that particular patient. So I'll just spend the next 8 minutes or so talking about the most common aortic anatomical challenges. So access, specifically iliac access, short neck, dilated neck, angulated neck, and then mural thrombus, usually at the neck. And so these are common things that we see in practice, and the risk of these challenging anatomical features is that we fail to seal. So we'll end up with a 1A leak or a 1B endo leak, maybe even a 3 endo leak. We can end up with thromboembolism in our kidneys and our legs. And then if you are one of the unfortunate vascular surgeons to end up with an iliac on a stick, it's not a good time. So we've seen all patients like this before, patients that come in with severe iliac occlusive disease, circumferential calcification, and we're trying to deploy our endograft to fix our aortic aneurysm. And so I typically will start, with a hydrophilic dilator over a stiff wire. Sometimes I get a little external pressure to try and straighten things out and get a little counter pressure, just the right amount of pressure to get that dilator up so you can get your sheath up. Sometimes if you have a very focal lesion in your iliac, you can just do plain old, balloon angioplasty for a very short area, but it's usually not a short lesion. Usually you're dealing with very long lesions. And so most of us, I think, will go to endopaving at this point. So this is your internal endovascular conduit. So this is balloon expandable covered stents down both iliacs, obviously trying to preserve at least one of your hypogastric in order to deliver your endograft. Many of us still do iliac conduits. So this is a nice little small retroperitoneal incision, and you're trying to put down a graft, usually a 10 or an 8 millimeter graft onto the iliac anastomosis. And sometimes this is nice if you're doing stage complex endovascular work. Sometimes you can leave that conduit in there and kind of tuck it underneath the inguinal ligament and come back and sort of thrombectomize it and kind of use it again. So we still do iliac conduits. This is not as advantageous if your common iliac or your aortic bifurcation is also calcified, then that might not be enough. I do not recommend uncovered stents when you're trying to get, your iliacs prepared for your EVAR deployment. I think there's really high risk for dissection and rupture, and it's just not a good idea. Dr. Bobrowski gave us a great talk on shockwave this past Midwestern in Minneapolis. I don't use a lot of it in my practice, but there's certainly increasing evidence that shows that you can use shockwave to treat these calcifications and these stenoses preoperatively in order to deliver your endograft. Iliac tortuosity, also an issue. Generally, the iliacs will straighten out over stiff wires, unless, of course, you have circumferential calcification, and then you're sort of just like pushing that lead pipe up, and it doesn't want to do anything but be a lead pipe. I do buddy wires often, a super stiff or a double wire, and then just take care once you get that iliac straightened out, you deliver your system, that you might want to change out for a soft wire, especially when you're thinking about your iliac limbs, measuring, and then also making sure at the end for your completion angiogram, so you don't want to avoid landing short or covering one of your hypogastrics. I find that oftentimes in these iliac lesions, the external iliac will sort of accordion on itself, and then you sort of are looking at the scalloped external iliac, and you're sort of wondering, did I snowplow it? Do I need to stent that on the way out? And oftentimes, if you take your stiff wire out of there, these sort of pseudo lesions often disappear. And then for me, through and through access is really probably the best option. So I like to go right radial, brachial. You have a surgeon at the top, a surgeon at the bottom, really kind of holding tight on that railroad wire, and then delivering your endograft or your sheaths to where you need them to be. And long wires are clutch. We're using more and more of the 300 centimeter wires to be able to get that through and through access, which is nice. So a short aortic neck. So there are devices on the market that have a shorter neck within their IFU, but typically is defined as less than 15 millimeters. I think most of us will go to endo anchors. So just getting a little bit better of a seal here if you feel that your neck is on the shorter side. Palmaz stent is an option. So I haven't done many of these recently, but I do recall that it takes a very careful mounting and deployment if you're going to do a Palmaz stent inside your EVAR graft. So you want to mount this Palmaz stent kind of off center here, off center of the balloon, so that when you blow up the balloon, you don't get watermelon. So you have a little bit more balloon out here. Keep your half of the stent inside your sheath, so you really get good apposition here. And it's sort of like a suprarenal fixation within your endograft, and then deploy the rest of your sheath. And then obviously, you can cuff up. So there are a few cuffs still on the market. Some of them are fixated, some of them are not. But if you are looking for 1 more millimeter and you have room, that is a good option. But in all honesty, if you are doing an endograft and the neck is really too short, my sort of feeling is that you should move up and try and get a better seal farther up. Lots of different options, won't go into them. Parallel grafts, we have chimneys that come down from the top. Sometimes you do 3 from the top or 1 from the bottom. What have you. You have fenestrated grafts, you have branch grafts, so lots of options. But basically, you're just moving your aortic neck, your seal zone up to try and get a longer neck. Angulation, so usually defined as greater than 60 degrees. I will say that there are at least 2 FDA-approved endografts out onto the market. I believe there's more across the pond. And I strongly suggest that you at least consider this for your angulated neck. They actually do work very nicely. I find that, with these angulated necks, if you're trying to stuff a graft in there and you get this bird beaking sort of on that inner curve, and you're thinking you're going to do an endo anchor, sometimes the endo anchor is just not long enough to get you to that aortic wall, and then you're not happy with your seal. A dilated neck, which is defined as 26 or 28 millimeters. Certainly by the time you're at 30 millimeters, you're basically at a pararenal aneurysm. So you're just fooling yourself. But if you have a greater than 29 millimeter neck, that's the strongest predictor for overall mortality for these patients. This is a nice technique that I've never personally used, but I feel like the theory is sound. This is the funnel technique. So you bring your EVAR in and you purposefully land it lower, below your renal arteries, and you're basically using your largest endograft that you, EVAR graft that you can, and then you come up through your limb and you bring up a thoracic endograft and hit that at the renal arteries there. And so the theories behind this is that your thoracic endografts are going to have much larger diameters, so you're able to get a larger diameter graft right below the renals and then seal within your actual traditional EVAR. You need to make sure that you don't bring that too far down and get in past your flow divider, so you don't couch off one of your iliac arteries. Mural thrombus, so this can compromise your seal zone. Greater than 50% of mural thrombus up at the kidneys is obviously risk for tooth pasting. You can embolize that and send a clot down the renal artery, which is a bummer. When you're all done with your EVAR, you have to go and get that out. I recommend that you avoid aggressive balloon molding for patients that have mural thrombus at the renal arteries. Sometimes if I'm very worried about it, I'll just get access from above, put wires down the renal arteries and just put like a 4 millimeter balloon in there, and sort of protect the renal arteries as I'm doing a balloon angioplasty. But essentially, if you have mural thrombus here, then, you know, it's not a great neck. It's considered a short neck. So consider moving up your device for a better seal zone with your fenestrated or chimney grafts. Or you can choose a endograft that has an alternative sealing mechanism that doesn't require balloon molding for that proximal seal. Then finally, a small aortic bifurcation. So this is pretty common in patients that have focal saccular aneurysms. So you have a normal sized aorta, fairly normal diameter all the way down, and then a big saccular aneurysm. So the issue with this is gate deployment. So when your bifurcation is getting down, IFUs are different, obviously, for each graft, but, you know, 18, 16 for sure. You worry about your gate popping here. So you deploy this down and your gate's sort of closed off. So you can go up and over and try and send your wire down that way. I like to come from the arm. I just feel like it's faster. Send a wire down the left arm and then sort of snare it in the iliac artery and then bring the wire out through your femoral artery. If you are going to continue and you get your gate to pop and you want to do your bi-iliac graft, you certainly want to do kissing balloons. I actually like to do covered kissing, covered stents, VBXs, and kind of just line this out so that you don't get occlusion of one of your iliac limbs. You can use a main body. You can't get the gate to pop, so you put a second main body in and turn the gate on the opposite side. That is a really expensive conversion to an aorta uni. Or you can just plan ahead and just do a regular aorta uni, plug on the other side, and then a cross-femoral artery to maintain blood flow to that other side. But I agree with Dr. Ambani. Please don't forget that for the surgeons on the call that we can do open aortic surgery. Open aortic surgery can be used in most patients with challenging aortic anatomy. We can do iliac aneurysms, we can do pararenal, suprarenal, we can do thoracoabdominal aortic aneurysms. So don't forget that that is one of our tools. Thank you.
Great, thank you for a wonderful presentation. Any, okay, we have a question from the audience. What happened to the tomo solo path for typical iliac access EVAR?
That is a great question, and I don't have an answer to that. Anybody on the panel ever use that?
I'm not familiar with this. Anybody chime in?
I have to confess, I was not familiar either, so I just Googled it. And apparently it was a sheath that was delivered at a low profile, and then you could expand it. And it was withdrawn from the market because it uncoupled from the tip. So
Yeah, I think it was
has an answer
initially,
for everything.
yeah, I think it was initially developed for valve delivery, and it didn't fully work.
It was we used it a lot. It was great. It worked awesome for us. But I think they had some manufacturing issues and it was relatively low adoption. So they elected to not pursue revising their manufacturing process and they abandoned the sheath.
Okay, that's great. Thanks for your comments, Andy. Do you have a distal aortic diameter cutoff for not using EVAR?
Carlos, do you mean at the bifurcation or do you mean at the kidneys, at the bifurcation? You know, when I was first starting out, this is like one of my very first EVARs that I did. It was a really tight bifurcation. And then I was back the next night opening up that limb. So I really look at that. So I definitely don't like to go below 16 for sure. But, you know, I think that if I'm at all concerned, I'll reline that with my VBXs and make sure that I get a good result at the end and try to not have to return to the operating room.
Okay, we'll move on to the next talk. The third presentation will be given by Dr. Ines Yasa, who is the Section Chief of Vascular Surgery at Frederick and Lena Meyer Heart Center in Grand Rapids. She also serves as the Program Director, Associate Program Director for the Spectrum Health and Michigan State University Vascular Surgery training programs. She is co-leads at the Aortic Center at Corewell Health West. And her talk today is going to be on partnering with cardiac surgery. Ines?
Thank you very much, Jay. I hope everyone can hear me and see my slides. So I've been given the honor of presenting on partnerships. I can confidently advocate that I think partnering with our colleagues in all capacities definitely leads to better patient outcomes. So I'm happy to talk on this today. Let me make sure I can move ahead here. These are my disclosures. I will be briefly discussing non-FDA approved device use. And I want to acknowledge Dr. Sukuhan of USC Keck School of Medicine, who did share some of his slides with me. As many of you know, he's also a strong advocate for partnership across vascular and cardiac surgery for building aortic centers of excellence. So, you know, I'm not going to do a lot of cases, but of course, everyone's more interested when I talk about cases. You know, this is an example of the type of patient that we take care of in our multidisciplinary aortic program. Our center takes care of, you know, gentlemen like this all the time. This is a 78-year-old male. You can kind of see as his CT scan scrolls through. He came to us with a descending thoracic aortic penetrating aortic ulcer. He had a chronic B5-9 dissection. He'd had a remote history of an ascending aortic aneurysm repair. And ultimately, to get the outcome that you see over here, he had a staged repair over the course of 6 months. Together, we sat down, we came up with a plan for a reduced sternotomy with a frozen elephant trunk. Intraoperatively, there was some, you know, minor complications related to that procedure during the same stay. He had his TVAR extended. He went to rehab. He came back. He had a 3-vessel PMEG in the same hospital stay. To the 3-vessel PMEG we did after allowing for some time for distal aortic recruitment of collaterals for spinal cord perfusion. He had a unilimb EVAR and a false lumen candy plug. We delayed completion until a few months later, and then ultimately, you know, had a very good outcome. So, you know, these are obviously different patients than our standard infrarenal aneurysms. And I think in order to really give them the best possible care, we have to think about how we can work together and talk across the aisle. Very popular thing nowadays. So what do we see when we work alone? I mean, I think for those of us, you know, certainly when I'm in my own vascular surgery office, you know, I see a lot of abdominal aortic aneurysms, even juxtarenal, pararenal abdominal aortic aneurysms, and that can be, can kind of make you sort of a little bit tunnel vision that that's, you know, the majority of the aneurysms that are out there. Certainly thoracoabdominal pathology is not as prevalent as abdominal aortic aneurysm pathology. I think most of us are familiar with these numbers here, but that's what we see when we work alone. And when we work alone, we are also, as these discussions, you know, expertly put together by the previous speakers, we know that there's a paradigm shift in abdominal aortic aneurysm repairs. You know, published by Anahita Dua and her team, we know that endovascular repair has really overtaken abdominal or open aneurysm repair. And that's not quite necessarily the current climate in thoracoabdominal aneurysm surgery. However, it could be, you know, that we start to acknowledge that endovascular repair of more complex aneurysms, you know, may be the better option for some patients. And I think, you know, there's a lot of data still to come that, you know, I think is pretty convincing in those arenas, but it's important even in abdominal aortic aneurysm repairs and in thoracic aneurysm repairs that we can do both and we can talk through both options. You know, I think once we step outside of just, or not just, but the abdominal aortic aneurysm pathology, we can remember, you know, even Dave Deaton's work from 2014, looking at 1,500 aneurysm patients. You know, aneurysm pathology is often a multifocal disease. More than 50% of patients who have thoracic aneurysms have aneurysms in other locations. And I think when we those patients are seen in isolation by cardiac surgeons, that's not always thought about. And 12% of abdominal aortic aneurysm patients also have thoracic aortic disease. And I think when we see those patients in isolation and we don't have exposure to the remainder of the pathology and the multifocal nature of the disease, we can sometimes certainly be at risk for being tunnel visioned and forgetting I do it too. You walk into one environment and that's what you start to think about. So what makes an aneurysm complex? I think our prior speakers have talked about this a little bit, certainly as we creep up to pararenal, paravisceral aneurysms, short neck aneurysms, juxtarenal aneurysms. And then we start talking about the classic, classifications of thoracoabdominal aneurysms. When we start kind of creeping up into type E of this group, or 1 through 5, here we're certainly, I think, perhaps looking at the type of patient who benefits from a multidisciplinary approach. I think it also behooves us to remember, and as I've been more participatory in our complex aortic and multidisciplinary clinic, the risk factors for thoracoabdominal aneurysm are perhaps more broad spread than we think about for abdominal aortic aneurysms. We have to remember certainly the correlation to intracranial aneurysms. Even renal cysts are predisposing to thoracoabdominal or to thoracic aortic aneurysms, which then subsequently predispose to thoracoabdominal pathology. Patients with temporal arteritis have been demonstrated in this patient series from Yale to be 2 to 8% more likely to have thoracic aortic aneurysms. And certainly patients with bicuspid valves, we know, have a 20 to 80% increased risk of thoracoabdominal aortic aneurysms. So, why does a multidisciplinary program matter? Is it just so we can get access to these, complex fenestrated devices, multi-branch devices? Is that why we want to build a multidisciplinary program? I don't think that it's as simple as that. I think certainly participation in multidisciplinary programs allows us to select patients and have access to patients that may be better suited for these devices, and certainly allow us to provide more options to our patients. But I don't think that's the extent of why any of us and why I would advocate for a multidisciplinary program in partnership with our cardiac surgery colleagues. I'm going to hopefully recapture people's attention by presenting another patient case here. This was a gentleman, a young patient in his early 30s who presented to us with a mycotic paravisceral aneurysm. As the CT scrolls through here, you'll see sort of this giant mycotic. I won't even call it an aneurysm, really. When we finally went to operate on him, none of this was contained aortic wall. So really a ruptured mycotic aneurysm. This was not something that we were going to treat with access to a custom-made device or a branch device. This is us patient, 5 years later. What we ended up being able to do through partnership with our cardiac surgery colleagues was on circ arrest, do a cryo-aortic repair with vein bypasses to his celiac and his SMA, as you can see here on the side of the screen. And ultimately he was unfortunately already in renal failure when he presented with this ruptured mycotic. And after recovery from this, his renal function really never recovered. We suspect we ligated his renal arteries intraoperatively in an efforts to get control. And then he went on to get a kidney transplant. And 5 years later, he's just had a new baby and he's very happy. So I think multidisciplinary aortic programs allow us to do more than just complex endovascular work. So again, why work together? I think what separates our aortic centers of excellence are truly this positive feedback cycle, where by working together, we increase our referrals, we increase emergent transfers, we increase educational and research opportunities, and then we have access to technology, and we can start to think about what are the ways that we want to take care of patients, not just what do we have access to. And I think I challenge everyone on the call who has, programs that they're building. Where can you enter into this cycle? Where is the opportunity for you to start or build, to partner better with our cardiac surgery colleagues? And I'm going to talk a little bit more about that building of a partnership now. So what are the challenges that I've heard as I've spoken to folks at other institutions, and certainly we faced as we were starting to build a partnership between cardiac and vascular surgery? So limited availability of complex patients, perhaps, low emergent or urgent patient volumes, limited access to technology. We've talked about awareness of the technology that's available. We may be very aware in the world of vascular surgery, but sometimes our cardiac surgery colleagues are not, really maintaining line of sight to all the, juxtarenal, pararenal, branched and fenestrated devices. Certainly there are cardiac surgeons who are heavily engaged in these trials, and there are those that are not. And so, your partners in your institution may need a little bit of awareness, and you would need, we as vascular surgeons, I think, need to be aware of what goes into doing the cardiac surgeon's job. And finally, competition from neighboring centers. So what are the solutions to building these partnerships? when we talk about limited availability of complex patients, I think that's where the opportunity exists to really foster the development of expertise, bringing together people who, this is, a primary focus or a primary interest for them, perhaps. And then sharing experiences in patients in environments like this, environments like, small group sessions, multidisciplinary conferences, cross-institutional conferences that allows us to kind of brainstorm together. I think when we talk about low, emergent, and urgent volumes, there's some efficiency that can be built into transfer center pathways. And building those care pathways allows for consistent care, which will always result in better outcomes. Limited access to technology, we mentioned this, and I think shared conferences, communication easily, partnership with industry that is willing to partner with both cardiac and vascular surgeons. We have a shared Heart and Vascular Institute town halls that are spearheaded by our department chair, Dr. Vic Kashup, and then certainly do multidisciplinary morbidity and mortality conferences where these patients are discussed and learning opportunities across all parts of the care pathway are shared. Competition from neighboring centers. I think the solution to this is really in the outcomes and the patient experiences. I think if you're, kind of in an environment where perhaps there's a lot of competition, you really just need to focus on good outcomes and excellent patient experiences. And then, from those endpoints, the referrals will come. So, this is an example of our transfer center pathway. Basically it starts at the beginning. We say yes. And then on the side of the screen here, you can see, so when our transfer center gets an incoming transfer for a type B aortic dissection, for example, we have an agreed upon pathway where cardiac surgery and vascular surgery are both engaged by the transfer center. Or if one of us receives the call and the patient is, malperfused or otherwise in need of emergent surgery and accepts the patient, the other is contacted immediately upon acceptance. If a patient is admitted for a symptomatic or rapidly enlarging thoracic aortic aneurysm or thoracoabdominal aneurysm, again, both parties are engaged immediately. If it's a complicated type B aortic dissection with malperfusion or rupture, I've highlighted in red here the pathways that may be, single team. That person's probably going to go directly to the operating room with vascular surgery. If it's an uncomplicated type B, it gets admitted to our cardiothoracic intensive care unit for monitoring, blood pressure control, et cetera. For an enlarging aneurysm, the imaging is reviewed jointly and a plan is developed in tandem. And that plan is any one of these three things, depending on what serves the patient best. If the call comes into the transfer center for a type A to streamline care and get that patient just, to the operating room as fast as possible, we don't expect that the vascular surgeon is going to be on the admitting call or the accepting call. But if our cardiac surgeons feel like they might need us intraoperatively, preoperatively to evaluate for some malperfusion that needs to be treated first, or postoperatively, then we are contacted and immediately available. And of course, any isolated abdominal pathology is managed in isolation by vascular surgery. So this is an example. It's not, the only way to do it, but this is what we came to our transfer center with and said, this is what we think is the best way. So if the transfer center gets a call with a type B aortic dissection, they know they're meant to get both of us on the call. If I notice, or one of my colleagues, in cardiac or vascular notices that the other is not on the call, then we make sure that we engage and communicate. So what has this done and what can this do for your programs? Well, data from 2016 was pre-EPIC, but this is just our inpatient admissions for aortic dissection as a primary diagnosis on a year-over-year basis. And you can see, keeping out the COVID years here, but our volumes just significantly increased. This is year to date as of August. And you can see we're on track to pass our previous numbers. Inpatient admissions with aortic aneurysms as a primary diagnosis, again, I think by having a multidisciplinary program, by having a strategy to make it easy to accept patients in transfer, by communicating with each other, then it's far easier to get patients into the system. And once the patients are in the system, we're better able to take care of them, better able to learn, and better able to offer optimal therapies in the future. One of the other things we run is an outpatient multidisciplinary aortic clinic as well. So any incoming referral for thoracic aortic aneurysms or thoracoabdominal aortic pathology, postoperative follow-ups after type B aortic dissection admissions, or status post-type A repairs with a distal residual dissection. They are sort of funneled into our multidisciplinary aortic clinic. Both cardiac and vascular surgery staff this clinic. soon to hopefully include perhaps some of our cardiology colleagues. Patients are lined up to go to this clinic. The imaging and history are reviewed jointly. The plan is again developed in tandem, and then the patient is seen either by a cardiac surgeon or a vascular surgeon in the same clinic environment. They don't go to see a cardiac surgeon and then follow up with a vascular surgeon. We see them together, we develop a plan, and the plan is communicated the same as whether it's conveyed by a cardiac surgeon or a vascular surgeon. And the plan is, again, any one of the things that anyone would assume. Either we decide that the person needs open repair and that workup and evaluation for suitability begins. They might need complex endo repair, and we plan that operation. They might benefit from a hybrid approach, and we discuss how to stage that, or they might just benefit from surveillance and further testing. And then we're all on the same page and can kind of remind each other about the importance, for example, of genetic testing for the appropriate patients. So what is our clinic structure for this multidisciplinary aortic clinic? Not all cardiac surgeons are interested in complex thoracoabdominal work, and not all vascular surgeons are interested in this. So we really tried to develop a core team of people who want to be there and who want to kind of, discuss hybrid ways or shared ways to develop plans for these types of patients. Future additions, certainly cardiology support, structural heart partnerships is, we kind of start thinking about the valve and onward. Mental health partnerships, genetic counselors, and lifestyle medicine are future potential partners into our multidisciplinary aortic program. And similarly, outpatient volumes, you can see that escalate, kind of just year over year increases in volume and discrete patient encounters for our combined thoracoabdominal pathology through our multidisciplinary aortic clinic. So, I'm just going to make a shout out here for our aortic dissection collaborative led by Shireen Shalhoub at OHSU. And this, just really nailed home for me why that mental health component and remembering that multidisciplinary care allows patients to feel like they're well taken care of. And for a lot of patients, the mental health impact of an aortic dissection is really substantial. These are quotes directly from patients that we interviewed for the purposes of this aortic dissection collaborative. The existential turning point in my life was being diagnosed with an aortic dissection. Mental health just doesn't always get addressed. Depression and anxiety play a big role in people's lives, but specifically in the Marfan's community, for example. And I think awareness of those things and creating a consistent message for the patient really goes a long way to the better patient experience and better patient outcome. So what are the roadblocks to partnership? I think these are all just things that have been tossed out. It's my patient, I should get the credit, my department should get the revenue. They, whoever they is, don't know how dangerous this can be. They don't understand the disease. They don't have the skills, whether it's the wire skills or the open skills. What I can offer is better. I've certainly heard folks say, well, if they can't have surgery, I'll send them to the vascular surgeon for a procedure. And why should I teach them? Whatever it is, it's not safe in whoever they are's hands. And these are just examples. I'm sure any of you may have heard them. I think it's important then, if we're going to embark upon complex aortic care, to establish some ground rules. We really have to have collaborative intent, mutual respect, recognition of non-overlapping and overlapping skill sets. We have to evolve care, be willing to share and partner, and willing to learn. And then we'll reach the common goal of playing nicely in the sandbox and having the best possible patient outcome. So, just one last example of a flow chart that we often use. This is, a patient with a thoracoabdominal aortic aneurysm either presents to the hospital if they're ruptured. If the answer is yes, they're ruptured, they're with outcomes for ruptured thoracoabdominal aortic aneurysms being, as most of us know that they are, not great. We're likely going to walk down an emergent PMEG, in situ FEVAR, snorkel, or parallel grafting route. If they're not ruptured, then we're going to risk assess them typically for open repair. If they're low risk, they might go on, or they have a connective tissue disorder that would be better served with open repair, then, we'll walk them down open repair or hybrid repair routes. If they're high risk at this point in time, we'll consider, are they appropriate for, willing to travel to a site that has, a trial device perhaps right now, or custom devices can be ordered, or we'll, at our institution, proceed with compassionate use of a physician-modified endograft with an IDE application coming soon, hopefully, for our institution. So this is, one last case that, I think highlights again the importance. This scan is scrolling through really quickly, but this patient has a 5-centimeter ascending aneurysm, a 6-centimeter proximal descending thoracic aneurysm, and a 5-centimeter type 4 thoraco. So all of these things have to be treated we can treat them in isolation. I can say, you know, well, I'm going to do my operation first and it doesn't matter, but really we need to build open reconstructions with a thought process to what are future endovascular interventions. And if we're going to perform endovascular operations, we need to keep future open repairs in mind. So if I'm going to fix this descending thoracic aorta, how does that impact this 5 centimeter ascending aneurysm and potentially arch reconstruction? So finally, what I'd say is, you know, this partnership, a partnership with cardiac surgery, is more than just a partnership with cardiac surgery. I think it's a partnership across all things in the heart and vascular service line. And remembering that by collaborating across these, patients get better outcomes when interventional radiology and cardiac surgery partner together, when vascular surgeons and interventional cardiologists partner together, and certainly when vascular surgeons and cardiac surgeons partner together, I think outcomes are inevitably likely to be better as well. And this is across all pathologies, not just aneurysms. I'll finally leave you with the voice of a patient. This is one of our patients who said, I just, you know, I'm excited now to come to these visits. I love knowing that a team of different specialists is working together and reviewing my case together to come up with the best plan for me. And if that's not convincing enough, know that the American College of Cardiology and the American Heart Association released guidelines in November of 2022 that said complex diagnosis and management of complex aortic disease should be done in a multidisciplinary environment. So finally, you know, what I'll say is, if you want to partner and you build it, they will come. Thank you very much.
Thanks, Ines. That was great. Clearly, we all have a lot to learn about how we can be better partners all together. If anybody has any questions, please put it in the Q&A. But for the sake of trying to stay a little bit on time, we're going to move on to our last talk. And we'll address any questions at the end. Dr. Louis Kabani, who is the program director for the Vascular Surgery Fellowship, as well as the vice chair of surgery at Henry Ford Hospital in Detroit, is going to talk to us about platforms for innovation, endovascular solutions for arch disease.
Good. Can you see my screen?
Yes.
Good. Okay. So thanks for allowing me to present. I was tasked with talking about innovations for aortic arch disease, and I'll do my best to talk about what's available and what's in the future. So disclosure, I have education grants from Tumor Gore, endologic consultations, and this talk describes off-label use of endografts. The transverse arch is anatomically defined as the segment of the aorta that includes the origins of the brachiocephalic blood vessels. When you think about how to treat them, you have to think of rerouting the head vessels, and if you want to do endovascular repair, you have to think about landing zones. Open repair was first described in 1957. It's still the gold standard. There's been a lot of innovations in it, including circular arrest with cerebral perfusion and elephant trunk with Fortune elephant trunk. But the mortality is still quite high, 5 to 15%, depending on what series is done. And the stroke rate is also pretty high, 3 to 12%. Failed patients have a higher 30-day and 1-year mortality, and many patients are denied surgery because of their comorbidities. Well, we tried to find easier ways to treat arch repairs, and we've come up with hybrid repairs. And we started with debranching. You could debranch zone 1 and 2, and you can even debranch zone 0. And depending on what type of debranching you want for zone 0, you can just do a simple bypass, or you can replace the whole ascending arch and debranch it. But this still gives us a relatively high mortality and stroke rate, and introduced new problems, endoleaks, including type 1A in about 13% of patients, and reinterventions in about 13% of patients. So it wasn't a really good result. Well, some people say, well, we don't want to do any open operations, and let's try to do this all with endovascular repair. And there's the three mechanisms came up. We've done chimney repairs, we've done laser fenestrations, and we've done branch endografts. Well, chimneys is basically a chimney or snorkel. You put a little graft beside the thoracic endograft, in hopes of maintaining perfusion to the cerebral blood vessels. And you could have chimneys in the carotid or the brachiocephalic, or you can have periscopes into the left subclavian. You need to have aggressive oversizing because the circumference of the graft is enlarged by putting a chimney. The problem with this circumflex is that you do have type 1 endoleaks, and endoleaks has been reported in up to 28% of patients with chimneys in the arch vessels. And the other problem is you have poor stem patency with a occlusion rate of patency rate of only 70% in some series. And basically, this is really not a great operation if you're thinking of a long-term solution for this problem. And this is one patient that we did a while ago, and we had encroached on the left carotid artery and put a chimney over here to help maintain the blood flow to the left carotid. In situ laser fenestrations is another technique. Technique is pretty simple. Basically, you put the grafts in, you put them on cerebral perfusion. Sometimes you do partial bypass for the carotids. It's really nice because it requires very little manipulation of the arch. You just put the graft in. And then you fenestrate it. So there's no twisting of the graft at all when you do the in-situ laser fenestration. And this is an example of one of our patients that we did a in-situ laser fenestrations a while back. You could see the good result with perfusion to the brachiocephalic and the left subclavian. The problem is that the grafts haven't really been designed for laser fenestration, and that's a problem because there's a potential increase for injury to the graft, type 3 endoleaks, and you don't know what the long-term patency of these grafts are, or how they're going to react to the laser fenestration. Another problem is really when you want to do laser fen, you need to have a good axial or perpendicular view of the vessel, and that's not always that's not very easy sometimes in complex arch pathologies. The laser probe can slip if you don't have a good view and could cause a tear in the aorta. In a meta-analysis, looking at 6 studies, the mortality rate was pretty low, stroke rate was pretty low, reintervention rate was not too bad, but you did have a fair amount of endoleaks, especially type 3 endoleaks at 3.5%. Upper branch endografts, well, that seems to be a good solution. There's supposed to be a good long-term durability of these grafts. The aortic arch has a high flow, high stress, and a lot of movement during the cardiac cycle. And there's been a lot of endografts that have been studied for this, including the Gore, Terumo, Cook, Medtronic, and Avitron. The Mona Lisa are no longer being studied with this. And there's also some grafts, including the Kawasumi and the Lombard Medical and PTMC, and these are in Japan. And the Reflow is actually a new graft that's coming out from China. They're good for pretty big pathology, 16 to 44 millimeters, but they do need a large access from 7 to 8 millimeters of the femoral access. The problem is, again, when you look at the combined thing, is a large stroke rate when you do these grafts at up to 14%. When I do think about total endovascular arch repair, it's good to think about either you're treating, you need a steel zone in zone 1 or 2, or you need a steel zone in zone 0. I think you should think of these patients a little bit differently. Zone 1 and 2 is probably a lot easier than zone 0. If you look at zone 1 and 2, you think about debranching or fenestration. And really, we all know the Gore TBE graft that's been out for a while. This is the landmark study, 238 patients, technical success rate of 95%, any stroke of 3.6%, disabling stroke about 2%, and left subclavian artery patency about 93%. Really good numbers when you look at this device. This device is, like we know, has a modular component. It has a left subclavian, a main body, left subclavian branch, and extension grafts if you need it. And if you want to put this device in, basically you did a access to the arm, access to the ascending, deploy the graft, and then put your subclavian extension into it. Cook has a similar device. It's a 1-branch device. It's custom made. Again, it's made for seal zone in 1 and 2. It has its own arch in it, so it auto adjusts to the arch, and you can have a single lumen, or you can add a fenestration or a single lumen. If you look at the current literature, stroke rate is still a little bit high on this device. Retrograde type A dissections was significant. Reinterventions were significant at 33%. Endo leaks is around 15%, and branch patency is reasonably good. How about zone 0? Well, again, the GO device can be used for zone 0. It's off-label. This is a study looking at using the GO device for zone 0. 9 patients, 100% technical success. But look at the stroke rate, 22%, pretty high. Again, the more close you get to the ascending aorta, the more manipulation, the higher the risk of a stroke. Cook also has a 2-side branch for the arches. Again, 30-day mortality was reasonable. Stroke rate 11%. Reintervention 23%. Pretty high. Cook has a 3-vessel device too. Again, stroke rate is 5% and reintervention rate about 20%. Still a little bit high in these patients. Terumo has a arch device too. Again, they looked at the patients, 43 patients. This was mostly in Europe. Stroke rate 26%. Disabling stroke 7%. Type 1 endoleak 2%. Not that, for the stroke rate, again, it's pretty high for these devices. Medtronic, the Mona Lisa, we knew about it. It's no longer being studied, but again, their stroke rate was 33%. Next is from Artivian is actually a very interesting graph. The deployment is actually into the innominate, and after you put it into the innominate, you have an extension into the ascending aorta. This probably decreases the stroke rate quite significant because you're not manipulating the arch or trying to get the head vessels in line. All you have to do is put it in the innominate and deploy it. And this is next device being deployed by one of my former fellows with the University of Michigan, University of Maryland. And again, it's a straightforward procedure. You deploy it in the innominate, bang, and then you deploy the ascending piece. This is the landmark study, 28 patients, success rate 100%, mortality 7%, stroke rate 3.6%, not too bad. Reintervention rate 11%. However, this is a case report of one of the Nexus devices being placed, and you can see it is caused by, there's a type A dissection. Again, one of the problems that we have with treating the arch and the ascending, something you have to be cognizant about. Reflow is another one kind of coming out of China. Very, very interesting device. You deploy your ascending stent. The ascending stent has 2 snorkels over here. You can see in the side branch over here. You cannulate the 2 snorkels, place them into the head vessels, kind of like a chimney, but they have a good seal, and then you place the rest of the device. We'll see how this device functions in the future. How about the future? Well, we've seen people talk about type A dissections. This is a study looking at 92 patients that they try to do a type A dissection. 10% required open repair, 20% endoleak, mortality 9%. Probably not the best thing to do. And when we look at the people who have a feasibility of doing endo repair type A, only 30% could be eligible for endograft. And finally, really the future, I think, is endovascular Bentel. This is a case report by the University of Maryland. You could see they did a visible modified graft, self-expanding aortic valve, put some fenestrations for the coronaries, and it seems that people are going to be working on this and trying to do a total endovascular repair of the whole arch. That's it. Thank you very much for listening.
Great. Thank you for a wonderful presentation, Roy. It seems to me that the stroke rate with arch manipulation is still very high, and I wonder if it seems to me that the indication for the procedure actually dictates the stroke rate. I don't know what your thoughts are about the different indications. For example, if you're treating residual type A dissection or type A dissection that involves the arch, those seem to have much lower stroke rates compared to patients with degenerative aneurysms or PAU involving the arch. So it looks like the indications has a very strong influence on the outcomes. Any thoughts on from your perspective or experience?
I think anything that's going to manipulate the arch, and if there's like disease in the arch, if there's calcium in the arch, there's thrombus in the arch, I think that's all going to increase your stroke rate a lot. I think it's difficult not to manipulate and not to have some kind of if you do a transcranial Doppler, I'm sure you're going to have some hits into the brain no matter what you do and no matter what device you put in. I think that's the really, if you want to have a really safe thing, you probably have to cut down the carotids, clamp the carotids, put on partial bypass, and even that's not 100%. But that's you have bad arch disease, like you said, a dissection with thrombus in the false lumen or a very nasty luminal thrombus or calcium. That's probably what you need to do.
You actually make an interesting point about different adjunct maneuvers, which requires open surgical techniques. And along with what Ines was mentioning in her presentation, I think, the way we were able to manage more complex aortic disease, whether that is involving the arch or thoracoabdominal, is not only because of advances in endovascular technology, but our ability to address these issues with open surgical techniques. Having said that, the open experience with vascular surgical training program is continuing to decrease as the endovascular technology is advancing. But in order to have meaningful presence in these areas, meaning more proximal aortic pathology, I think we need to maintain and continue to improve our experience with open surgical techniques. Any thoughts on maintaining that, or so by programs such as Open Aortic Fellowship and things of that nature? Any thoughts from the panel?
I'll start if that's okay with you. I think you're right, Jason, that you are going to have some places that have an advanced aortic fellowship, like it or not. I think they're going to have to go work with Yanis and then work and do some of her complex open surgeries or Cleveland Clinic. That's just the way that, and you have to remember, not every vascular fellow wants to do complex aortas. You have people that want to do fistulas and PAD and don't want anything to do with the aortas. So people need to we need to be able to offer the trainee what he wants, and that maybe like a fellowship, super aortic fellowship someplace. I think, Ravi, you tell me, I think you have in Cleveland an aortic fellowship, correct?
Not anymore. The cardiac route has an aortic fellowship, but we work very closely together on our thoracoabdominals and even complex arch repairs with, Dr. Roselli has a B-Safer IDE, and we do all these cases together to kind of give us the best outcomes. I think what Ina said was collaboration is really the key here, right? Put kind of everyone's brains together to give the patient the best outcome. I think we all have different skill sets. I think, relating back to your talk, I think one of the things that the Nexus device has, as you mentioned, compared to the other devices, is because you're just deploying into the innominate, you're taking the device once across the arch, right? The other devices, sometimes you have to go forward, then come back, then go forward again, and you have to reposition. I think that has to be contributing to the stroke rate for these devices. So I think, using both the cardiac knowledge, the vascular knowledge, and putting everything together is how we're going to get these patients to have better outcomes and really push both fields together.
Ines, can I ask you one question? In the interest of time, I'll just limit to one question. How many multidisciplinary aortic clinics do you guys have where both cardiac and vascular attendings come together to see patients? Because I'm sure there are more than one vascular or cardiac surgeon interested in doing complex aortic work. So how is it a very specific, operational question. How many such clinics do you guys have a week?
Yeah, good question. We actually kind of funnel them all into 1 or 2 clinics a month. And then the way we've chosen to do it is kind of, rotate cardiac and, up and hopefully rotating in other vascular surgeons who can kind of speak to the complex endovascular approach. And then, really, even though I think the key to it is recognizing that, it may be a vascular surgeon and a cardiac surgeon who actually see the patient, but as long as we're all on the same page, coming up with a complex plan, and then we can go and communicate that plan. I think when the kind of base of communication is there, then we have a better chance of propagating that plan forward. It's pretty rare that a patient sort of comes into that type of clinic and has a complex aortic plan developed, and then it's just set into motion in one office visit. Often the patient has to come back. And then as long as we have respect for each other's kind of plans that got developed in the first place, then through that process, we know that we're not going to change the plan on the patient every single time. So that partnership and mutual respect has to be built up front. You can't just say, okay, we're going to run a multidisciplinary aortic clinic and everyone is going to just rotate through. But we're going to maintain kind of not really having consistent messaging or consistent plan or mutual respect for a plan that's been made. So laying the groundwork, I think, in advance, as probably most of you have done in your institutions, is really critical.
Teresa, any other?
No, this has been great. All of our speakers gave great talks tonight, which have left us all with things to reflect on. Again, thank you to our sponsor for tonight's event, Terumo. And with that, we look forward to seeing everybody at the next New Horizons webinar series.
Thanks, everyone. Good night.
Yeah.
Thank you.
Bye-bye.
Thank you.